Welcome to our strategic framework for understanding cardiovascular health challenges and innovations, where we break heart disease into three analytical pillars: prevention and risk modeling, diagnostic pathways, and therapeutic frontiers. The circular diagram on the right highlights how data analysis, clinical insights, research, and global impact interact to drive better decisions and new interventions across the care continuum. This slide summarizes the economic and societal burden of heart disease, showing direct medical costs in the hundreds of billions and indirect losses that push the total toward multi-trillion-dollar impact annually. The graphics illustrate how these costs translate into catastrophic household expenses, rising poverty for millions, workforce attrition, and widening gender and intergenerational effects, underscoring the urgent need for preventive investment. The pathogenesis graphic walks us from common triggers like hypertension, smoking, and dyslipidemia to endothelial injury and LDL infiltration, then into a progression of inflammatory recruitment, foam cell formation, and fibrous cap development. As the arterial lumen narrows, the risk shifts from chronic ischemia toward plaque rupture and thrombosis, which can precipitate acute ischemic events such as myocardial infarction or stroke. This slide maps how ischemic heart disease moves from stenosis and plaque rupture to acute and chronic outcomes. Limited oxygen supply causes exertional ischemia, while plaque rupture leads to abrupt thrombotic occlusion and myocardial infarction. The post-MI cascade then includes reperfusion injury, contractile dysfunction, progressive heart failure, and, in severe cases, sudden cardiac death, illustrating both immediate and long-term consequences. The lifestyle slide emphasizes prevention as central to cardiovascular health, showing that quitting smoking can cut coronary events substantially, about a third fewer within 2 years, while diets rich in vegetables, whole grains, and omega-3s help lower LDL and blood pressure. Regular physical activity, roughly 150 minutes a week of moderate exercise, improves endothelial function, reduces inflammation, and offers powerful protection against risk. This panel highlights key, modifiable, and inherited drivers of heart disease risk. Sustained hypertension above 130/80 significantly raises risk. Diabetes accelerates atherosclerosis via glycation and oxidative stress. Dyslipidemia with elevated LDL or LPA increases vulnerability. And polygenic risk scores help quantify inherited susceptibility to guide early screening and prevention strategies for high-risk individuals. Here we outline advanced diagnostics and risk assessment tools that shorten the time to accurate decisions. High-sensitivity troponin permits very early MI detection, NT-proBNP gauges, heart failure severity and progression. Coronary, CT angiography, non-invasively visualizes plaque burden, and integrated risk stratification combines imaging with lipid and inflammatory markers to refine prediction beyond traditional scores. The electrophysiology and rhythm diagnostics slide shows how non-invasive and invasive tools complement each other. A 12-lead ECG identifies arrhythmias, conduction blocks, and prior infarction patterns. Holter monitoring captures intermittent atrial fibrillation and stroke precursors, and electrophysiology studies localize accessory pathways and ventricular tachycardia origins to guide catheter ablation and device therapy for sudden death prevention. This pharmacology overview connects mechanisms to clinical impact. Statins reliably lower LDL by 30 to 50% and reduce events regardless of baseline cholesterol. Antiplatelet agents like aspirin and P2Y12 inhibitors prevent thrombotic recurrence. Beta blockers and ACE inhibitors mitigate post-infarct remodeling. And newer agents, such as SGLT2 inhibitors and ARNI, extend benefits for patients with heart failure and reduced or preserved ejection fraction. The interventional and surgical slide lays out options for restoring flow and addressing structural disease. Percutaneous coronary intervention with drug-eluting stents is a minimally invasive, time-sensitive approach for acute MI, coronary artery bypass. Grafting provides superior long-term outcomes for multivessel disease and many diabetic patients, and transcatheter valve and mitral clip procedures offer less invasive solutions for valvular defects. This population-level diagram links policy, community programs, and workplace initiatives to improved population health. National measures like tobacco taxation, trans fat bans, and sodium reduction lower cardiovascular mortality. Community efforts, such as walkable cities and blood pressure screening, enable early detection, and workplace wellness, plus insurance incentives, help embed heart-healthy behaviors to reduce overall disease burden. The final slide describes an integrated, personalized prevention model that combines data inputs, genetic risk scores, coronary calcium scoring, and lifestyle audits into an integrated score with tailored targets for cholesterol, blood pressure, and glucose. That assessment feeds dynamic behavioral empowerment through mobile apps and telehealth coaching, providing real-time feedback and sustained support to prevent first or recurrent cardiovascular events.